ladies and gentlemen, I am so honored to welcome Dr. Pawan Kapoor, who will be delivering a talk on patient safety initiatives and implementable solutions. To welcome him, I'm equally honored to request Dr. Reba Kanungo to please do the honors. Dr. Reba Kanungo.
Thank you, Dr. Meher. It's really been a pleasure to be invited to introduce such a eminent personality as Dr. Pawan Kapoor. I must at the outset thank you and the organizers for giving me this opportunity to be part of this wonderful initiative that you have taken in tying up a global program to look at the antimicrobial resistance, antimicrobial stewardship, and patient safety. Now, it gives me great pleasure, and I'm honored to be introducing to the August gathering Dr. Pawan Kapoor. Dr. Pawan Kapoor, Air Marshal, retired AVSM, VSM, and BAR, former Director General of Medical Services, Indian Air Force. It's really indeed an honor to have a person from the defense, sharing your experience with us in patient safety. And what can be more pertinent than looking at safety of the population which you've been looking at, taking care of, and now we listen to you for the safety of patients. Air Marshal Dr. Pawan Kapoor is a hospital administrator of national and international repute. He is one of the founder members of the National Accreditation Board of Hospitals and Healthcare Providers, the NABH, and has been holding appointments as Chairman of Technical Committee and Chairman Accreditation Committee of NABH. He is a member of the International Society for Quality in Healthcare, ISQA, and is an international lead assessor for them. He had held the appointment of Commandant of Aerospace Medicine, the President of Indian Society for Aerospace Medicine, and Honorary Surgeon to the President of India with effect from July 1st, 2016 till December 31st, 2017. He is Vice Chairman of Reuse Education and admissions to medical universities in Russia, and visiting Vice Chancellor of Lincoln American University, Guyana. For his distinguished services, he had been awarded Chief of Army Staff Commendation thrice, Ati Vishist Seva Medal and Vishist Seva Medal twice, CAHO Lifetime Achievement Award, and AHA Ratna Award. He is also the recipient of his Order of the Royal Emblem of the Sultan of Oman while on deputation to SOLF from 1984 to 1987. With this introduction, I now request Dr. Pawan Kapoor to take us down the patient safety strategies, which is so very essential in protecting the patient and protecting the human race against the calamities that befall us through the irrational use of antibiotics. Dr. Pawan Kapoor.
Thank you, Dr. Reba. Good evening, good morning, good afternoon, salam alaikum, and to everyone who are here with us. My thanks to Dr. Meher Rizvi, to Sultan Qaboos University, to the American Society for Microbiology, the Hospital Infection Society of India, for giving me this opportunity to share my thoughts and my ideas about patient safety. Thank you, Dr. Reba, for such a wonderful introduction. And Dr. Meher, I think you have tried to put in too many people together and to come across and attend today's program. So special thanks to you. It's not very easy to get so many people together to come and discuss a subject of such a high importance today globally, not only nationally, but internationally. Before I begin, I must pay compliments to DASH project for protecting antibiotics. You know, this is something. I think about 62 centers today participating in this. Their representatives are present here. There can be no greater national and international service nationally and globally than to protect your antibiotics. And all of you have come forward to do this. It is a Herculean task, but I always say that everything becomes difficult if you cry, but everything becomes easy if you try. And DASH is trying to make things easy for a future. So a lot of compliments to DASH. Myself, I feel like a small microbe in this galaxy of microbiologists and infection disease specialists, but I'll try to take you all on in my own little way on a very last subject of patient safety. Before I begin, I must say that most of the views that I express here are of mine. Those of us who have similar views, they share similar thoughts or may have read the same papers or same content somewhere. Whatever case studies I present in this are actual case studies which have happened on ground. So if anybody is familiar, please maintain confidentiality. And lastly, questions and comments will be asked for during and at the end of this session. If you don't ask, I will ask. So the anatomy of my presentation will be on what of patient safety, the why of patient safety, and the how of patient safety, what initiatives and what implementation can be carried out at our level, at local levels, at regional levels, at national levels, and at international levels. So let's move on to what. I don't know how you all take patient safety as and what to express as patient safety. I would say patient safety is freedom from unintended harm due to healthcare interventions, because I believe no physician wants to intentionally cause any harm to anybody. So patient safety is freedom from unintended harm due to healthcare interventions. For a period of time, patient safety is becoming a discipline which is emphasizing that data related to adverse health events and medical errors should be collected, should be reported, should be analyzed so that necessary corrective and preventive actions can be taken to ensure that these are not repeated. This is what WHO defines patient safety as. WHO says two things. One is you must try to reduce the risk of unnecessary harm to the bare minimum. And second is there should be absence of preventable harm. So what harm that can be prevented due to the process of healthcare, that should be zero. Preventable harm should not occur. And if there are certain things in which you cannot avoid, which are unavoidable and not preventable, they should be reduced to the acceptable minimum. Before I move ahead, I would like to take you certain taxonomy. What is a patient safety event that may have or could have resulted in harm? And what are certain terminologies we should be using over and over again? One is a near miss. A near miss says that a patient safety event which has not reached the patient. What does it mean? That supposing I have prescribed an antibiotic, and that antibiotic is required to be given after an antibiotic sensitivity test, and just in the nick of time before administering the antibiotic, we realize that the antibiotic sensitivity test has not been done, and we do not administer the antibiotic. This means a patient safety event could have occurred, but did not occur, did not reach the patient. It is a near miss. Second thing is this, we do not do the antibiotic sensitivity test and we administer the antibiotic, but nothing happens to the patient, no adverse event takes place. In such cases, we say it is a no harm event where the patient safety event has reached the patient, but it has not caused any harm. And the last thing is an adverse event, which is, in which case the healthcare incident has caused and harm. That means you are given an antibiotic without doing the antibiotic sensitivity test, and that has caused an anaphylactic reaction. What is the sentinel event? The sentinel event is one where it has reached the patient and has resulted in any one of the following: either death or permanent harm or severe temporary harm. So these are certain definitions which we must know so that we learn to recognize patient safety events even before they occur and before the harm occurs or before they get converted into a sentinel event. Let's revisit some olden times. We all have taken Hippocratic oath, which says that we must prescribe regimens for the good of your patients according to your ability and your judgment and never do harm to anyone. And since then, the directive primum non nocere has become a central tenet for contemporary medicine, that is, first do no harm. So it is built into a system that we are not supposed to do any harm. Everything should be for the benefit of the patient. So why should we talk when everything should be for the benefit of the patient? Is there a need for us today to discuss patient safety? We say, no, it is not required, all is well. So let us see this cartoon. It says here that the rate of medical errors is stunningly high. The other patient says, well, that explains my hysterectomy. So obviously, all is not well. The message is loud and clear. Let us see by some data, is it true that all is not well? So let us see the whys. This is a WHO fact file. 1 in 10 patients is harmed while receiving hospital care. 1.4 million patients worldwide suffer from healthcare associated infections. In developed countries, the rate is around 5 to 10%. And the risk in developing countries where data is not collected, not analyzed, not reported is almost 2 to 20 times higher. There are 70% reuse of unsterilized syringes and unsafe injections are causing 1.3 million deaths each year. 50% patients requiring surgery in developed countries die or have disability due to unsafe surgery. And 50% of medical equipment is unusable or partially usable. Chance of harm of air travelers is 1 in 10 lakhs and chance of getting harm during healthcare is 1 in 300. There are 100 near misses for every adverse event which results in patient harm. And 37% of adverse events are highly preventable. And if you see the data on percentage of diagnostic and therapeutic errors in those countries where there were reportable systems, where they collect data and they have data analytics, you can see it is varying from 22 to 34%. So I will now present some of our very own case studies. I don't know, you may be familiar with them or not, but you will try to be with this case study to see that yes, sometimes in our career, these events have happened. This is a 30-year-old lady undergone a laparoscopic hysterectomy in a hospital whose OT has just been repaired. And a tile from the false ceiling of the OT falls on her outstretched hands and she sustains fracture of the lower end of radius. Now imagine the relatives have sent her for a hysterectomy and she comes out with a plaster on her hands. What impact it will make on the patient, on the relatives and the rest of the people who are sitting there. Second is another 55-year-old lady who has undergone coronary artery bypass graft surgery and currently in ICU. On the second post-operative day, she shows features of restlessness, anxiety, and inability to sleep. Very common post-operative behavior in case of patients undergone CAB and in patients admitted in ICU. Nursing in charge rings up the doctor at 6:30 p.m. and doctor advises 10 milligram of compost to be given orally. The lady visits the toilet. There is a time for turnover of the hospital staff at 7 p.m. and the turnover policy says that all medicines prescribed during a shift should be administered during the shift. The nurse visits the patient bed. The patient is not there on the bed. The nurse visits the patient in the toilet and gives her 10 milligram compost IV. Very dedicated, very committed nurse. And the next thing that what happens is that when the nurse change comes and looks at the bed, she finds that bed empty. She goes to the toilet and she finds the lady is in deep sedation on the floor with a lacerated wound forehead. Two ladies, both aged 28 years and both named similarly, that is Leelavati. One has come for cervical ligation for recurrent and midterm abortion, and another one has come for dilatation and curettage and evacuation for MTP. The procedures get reversed because of similar names, and you know how heart-rendering this situation is for both of them. Again, certain lab investigations of fasting and postprandial blood sugar and lipid profiles, they continue to show higher readings. And many patients have been put on anti-diabetic and statin treatments till one of the affected individuals get investigated from another lab, and he says that my other lab has said that my status is normal. How you are putting me on these drugs? When you investigate and you find that the equipment of this lab has not been calibrated at all, and also the reagents are expiry date. This has happened to one of our Air Force pilots, admitted with fracture avulsion of a distal phalanx left ring finger, taken up for surgery in a tertiary care hospital. After surgery, when the patient woke up, he found that he has got more pain in left middle finger than left ring finger. So now the surgeon reveals that he had accidentally explored the left middle finger initially, and subsequently realizing that he has made a mistake, he did the corrective surgery on the right. Okay, on the right finger, on the left ring, ring finger. Now another 65-year-old patient who had undergone transurethral resection of prostate. He was going repeatedly to the toilet. It is very common to check out the flow of his urine. And on one such visit to the toilet, he slipped, fell, and sustained fracture neck of femur. This is a very, very sad case study. A 47-year-old lady who had undergone hysterectomy 2 months ago reported with frequent bouts of fever and pain in right iliac fossa. Ultrasound revealed fluid collection and query of foreign body. The lady was taken up for laparotomy and they found a pus-soaked gauze piece adherent to the colon, which was removed along with a piece of the ascending colon. The matter did not end here. The same lady comes back to the hospital 2 weeks after discharge with the same complaints and similar ultrasound findings. Laparotomy revealed another retained gauze piece. We did not learn from our errors. And what error took place? This is a classical case of counting error by the sponge counting nurse. 8 gauze pieces had gone in and 8 had been accounted for. That included the one which was removed. So one was left behind. You see how a simple error can result into a sentinel event. This is one of those case studies. A physician writes an order for adding primidone, that is misoline, to the existing medication for a 12-year-old boy with a seizure disorder. Misreading the physician handwriting, the pharmacist mistakenly dispenses prednisolone. For 4 months, the boy receives prednisolone along with his other seizure medications, causing steroid-induced diabetes. And this child, unfortunately, goes into diabetic ketoacidosis and dies from it. Now, this is another classical case of communication error, which I want to discuss with you all. See, what is the very simple thing? 55-year-old paraplegic mother on a wheelchair in a paraplegic center was given an outpath to spend a day with her daughter, who was explained that her position has to be changed every hour to prevent decubitus ulcers. When this lady reports back in the evening the nursing staff who had tended to her for almost 3 months discovered to their horror that the sanctity of the sacred skin had been breached. Now, what happened in this case? On inquiry, the doctor expressed surprise because she said she had been moving that wheelchair every hour. Now, instead of telling the daughter that she's supposed to move the mother change the position of the mother every hourly, she understood how to change the position of the wheelchair every hourly, and this is what happened. So let us go back and think when healthcare technology and all these things did not exist. Life was very simple, you know. To take history, do some inspection, do some palpation, do auscultation, get some basic lab results done, and do the treatment. Practice of medicine was simple. Maybe it was relatively ineffective, but was very, very safe. We were never taught patient safety in our medical schools. Not that it is being covered now, but patient safety was not even considered in our practice in the earlier stages. But with the advent of research and healthcare technology, what has happened? Babies are dying in the incubator. Government are filing complaint against faulty X-ray machines. Many incidents have evolved where the battery-powered defibrillators and monitors have failed to discharge during cardiac emergency responses. You can see repeated news: incubator turns furnace, 5 infants killed in incubator, fire in hospitals, superbug discovered, irrational use of antibiotics, causing ICU to become centers of superbugs. Avoided confusion everywhere. Everything is, marketed in the same way, so you don't know what drug you are prescribing. This is the state of affairs in the operation theater. So is there a mismatch now between technology, between us, between our knowledge, and between what we apply? Now practice of medicine has become complex. It is probably more effective than what it was in the past. So many diseases have been eradicated. The lifespan has increased, the life expectancy has gone up. But maybe practice of medicine has become potentially dangerous too. And are we not, like you said in the first slide, are we not going back to the pre-antibiotic era? Diathermy, surgeon and patient, you see the rotary burns that occur due to diathermy. Patients are falling off from stretchers. Yeah, other sample problems, one of them happened in front of me where a motorized table, while operating, the head end of the motorized operation table broke, but by luck, the patient neck was saved due to the presence of mind of the resident anesthetist. What I have told you is just tip of the iceberg. What lies beneath is massive because we don't have the data. We don't know what is happening. How much unsafe our patients are. Where it has been said that doctors are more dangerous than guns, and it can be statistically proven. Number of doctors 70,000, accidental death cost by doctors per year 120,000, hence accident per year per doctor is 1.714, courtesy USA Department of Family Welfare. FBI gives this data: number of gun owners 80 million, accident death due to gun 15,000, accident per year per gun 0.0001875. Therefore, it can be easily proven that doctors are 9,141 times more dangerous than gun. What does it mean? Are we callous? Are we careless? Are we casual? Or just we are not concerned? When mistakes happen, this is the mantra that we should follow. Keep your fingers on your lips. Nobody should come to know. Push it under the carpet. Who is responsible? Doctors, nurses, other staff? I don't know. If I had a live session, I would have put to vote. Most of you would have said that it is all of them. But my take is that it is none of them. Why? Because it is a systems failure. And the systems failure arises from the fact that we discuss, we deliberate about patient safety, but do nothing about taking initiatives for improving patient safety and delivering quality of care. So if you see this question, I would have asked you in a live session this question, but I'm not going to ask you this question, that if in a hospital like this, where you're having repeated cases of blood transfusion reactions due to incompatibility, where inpatients are falling leading to injuries, where wrong side surgery has been done, and a medication dosing error leading to patients that have occurred, what could be the most probably single underlying cause behind these events? I would have no hesitation in saying that in this hospital, there is a systems failure. And why human beings, they make mistakes? Because the systems, the tasks and processes they work in are poorly designed. So the aim of my today's talk is to ensure that we design our system, tasks and processes in a manner that our professionals, our para-professionals, our nursing staff do not commit mistakes. So what we need to do, the how. When we make mistakes, we must look into the mirror, we must introspect, we must report, and we must take an action, we must prognosticate, we must plan, make policies, and we must perform as per those policies. Why are we here? Because of this reason. We have to plan, make policies, and perform. See, the current environment, we have seen that errors continue to occur and recur. We do not take action on the risks. We do not like to detect because we are shrouded with mystery and defensiveness. So therefore, most of the events are not reported. Therefore, we don't understand the causes of occurrence of those events. Therefore, we cannot measure the impact in our hospitals and across the country on that event. And whenever something is discovered or diagnosed or reported, we blame somebody who did it and we penalize that person. So blame culture is alive and well. This is the current environment. But why we are here? We are here to create awareness, to say that we are willing to change our attitude and our behavior. We are going to identify the problems and challenges as to why patient safety incidences are occurring. We are going to understand the causes. We'll develop solutions and system solutions, not individual specific solutions. We'll implement those changes based upon these solutions. We'll embed those changes in everyday practice so that it becomes a routine, well-oiled affair, and we monitor for effectiveness. This is why we are all here together. Patient safety is just not about statistics, but it involves damages to the lives of real people. And therefore, patients have to be at heart of all patient safety initiatives. Here are some of the initiatives. WHO has taken initiatives. We have certain national initiatives in all governments. In India, we have got national initiatives taken by the National Education Board for hospital and healthcare providers, where we have a patient safety framework, a patient safety goals, and we also have proper hospital infection control, standards. There are local initiatives like this initiative taken by you for DASH to protect antibiotics, the initiative taken to get all of us together and for us to share our experiences. These are all local initiatives. I will focus on some WHO initiatives based upon the World Alliance for Patient Safety. And most of us are signatory to this World Alliance as member states. They have said these safety challenges. This is there are about 12 action areas. I will only discuss 2 action areas. The first action area is clean care is safer care, safe surgery saves lives, and tackling antimicrobial resistance. These are 3 most important global safety challenges which we all have to come together, and we are taking steps like this step taken by Sultan Qaboos University. It's a wonderful step. And this is to protect antibiotics. That means you're going to in future tackle these antimicrobial resistance. Then next is to engage the patients. If the patients are not engaged, because what patient does, he goes to the private practitioner, he says, okay, I have been having fever for 3 days, I'm having these issues. And he expects you to prescribe an antibiotic because he has read somewhere that the antibiotics are to be given. And you don't give him antibiotics, then you are not a good private practitioner, he will go to somebody else. So patients have to be engaged and only then we can actually look at patient safety by engaging patients for patient safety. So they have to be involved in all aspects of safety. There are certain international patient safety goals that relate to patient identification, effective communication, medication management, safe surgery, healthcare associated infections, and patient harm from falls. So we should have our own national framework for patient safety. We should create awareness by having more such webinars, more such workshops, and take very simple measures in our own hospital for patient safety, which I'll tell you shortly. These are the doctor's toolkit for patient safety. I call them, these are simple measures which will save lives, which will save embarrassment, and which will save you litigation costs. The simplest thing is accuracy of patient identification. So have two identifiers with ID bands with your admission discharge number, and you can elicit the patient name from him or her. These are some examples of identification based bracelet. The second most important thing is taking care of communication errors. There are many errors. I told you there were certain verbal orders given by giving compost orally, they gave intravenously, and also how that girl moved the wheelchair instead of the patient. Most communication challenges do not have a life and death situation hanging in balance. But in healthcare, every conversation can have that life and death situation balance. 70 to 80% of our medical errors are related to interpersonal communications, and 63% of central events occur due to communication breakdown. So we must improve communication. We must have bedside patient handover, not only on documents. Yes, you must document in the appropriate tool, but bedside patient handover is important. You must repeat and record all telephonic and verbal orders. Capitalize your drug orders, have good prescription practices which are legible, and use only standardized abbreviation. I will tell you, I was shocked to find somebody writing FeSO4 1-TDS. Now, if you do not know what FeSO4 stands for, you don't know what drug the patient is going to get. Incidentally, he wanted to give ferrous sulfate. Again, critical alerts should be communicated and they should be followed up to complete the route. If there's a critical alert value, that is abnormal lab values or X-rays, they should be immediately informed to the licensed caregiver, which can be vital for patient safety. Then improve medication management practices, that is follow the 6 hours right medicine for the right patient at the right time and the right dose in the right by the right route by the right person. So write legible prescriptions. Be aware of look-alike and sound-alike drugs. Do not store them together like Roxin and Roxin, ROKCIN and ROXIN. One is an antibiotic, other is a thyroxine hormone. Havoc can take place. Please label the high-risk medications and label all medications in various containers. You can see how look-alike drugs can create havoc here. You see how prescription can be made in the pharmacy. They keep these boxes for prescribing person. This is for this, this is for this. This I've already told you. Another important thing is reduce the risk of healthcare associated infections. So CDC has said very clearly, wash hands for at least 15 seconds. You might like to sing happy birthday to yourself while washing your hands. You can use waterless hand cleaners when soap and water are not available. Don't wear artificial nails in patient care areas and know when to use the correct hand hygiene. These 5 moments, I think everybody knows, seldom practiced in many areas. We have done so much analysis. The compliance is never more than 65 to 70%. And these 5 moments are before your patient contact, after the patient contact, before doing any aseptic task, and after coming into touch with body and fluid exposure, and after contact with patient environment. The certain pillars of HIC program, I will not go into these pillars in detail because they are themselves a separate talk. One is to have a hospital infection control manual. That manual should address standard precautions with focus on hand hygiene. It should address the disinfection and sterilization practices. It should address OT and ward practices. It should address antimicrobial usage policy. the rational use of antimicrobials, the antibiotic stewardship program, and antibiotic prophylaxis. If all this is addressed, most of the problems of healthcare associated infections can be controlled. The last one is risks from harm from patient falls, and that you can put some sign like a leaf magnet, something, so that everybody knows that this patient is a risk for fall. So they will try to make sure that the patient is safe and secure. Implement surgical safety checklist. I am sure most of you know the WHO safety checklist for sign in, time out, and sign out. So at the time of sign in, you must confirm the patient identity, the procedure, the consent, and the site. Site is marked if it is applicable. Anesthesia safety checklist is completed. You must ensure that pulse oximeter on patient is functioning. Does the patient have known allergy, any difficult airway? Is there risk of blood loss? All these are taken into consideration at the time of sign in. At the sign out time out, everybody must identify themselves, must understand their roles, must anticipate the critical reviews both by the surgeon and the anesthetist and the nursing team, and then check for antibiotic prophylaxis whether it has been given and is essential imaging displayed or not. So that pilot who had the wrong operation, he would not have had this operation if the imaging had been displayed. In time out, in sign out, the nurse verbally confirms with the team whether the specimen has been labeled, the procedure has been recorded, instrument sponge and needle counts are correct, and surgeon, anesthesia, and professional nurse review the key concerns of the patient. The last simple measure is all that you can do. You can have risk management committees to identify, do risk assessment, do employee training, lay down policies for biomedical waste management, have process management like frequent fire and disaster drills, safety around prescription, nursing, and clinical audits to arrive at various problems that are being faced by these audits. Do inspection of all your equipment before you are embarrassed or before an adverse event reaches the patient. Daily questions you ask: what did you do well today? Replicate it. Any harm that occurred? Then, if patient care, past harm is taking place, presently is the patient safe from that harm? And are our clinical systems and processes reliable? Daily question to ask yourself before you go to your workplace and start doing your work. Is care safe today? Will care be safe in the future? And are we responding and improving? That means, are we learning from our experiences? These are very important questions on a daily basis. Employees, they must report any potentially dangerous patient situation to the supervisor. They should participate in performance improvement processes in the department and take their annual mandatory training seriously. And if there is no training, please, this training should be introduced. It will help you to at least identify the safety issues. Please do not take shortcuts. Whenever you take a shortcut, rest assured a mistake is going to happen. Use your checklist. Ask your co-workers to complete double checks and allow patients to participate in own care. Yes, patients, what they can do for their own safety, they must participate in own care, give honest disclosure, follow instructions. When in doubt, seek clarification. Don't be your own doctor and report for follow-up as scheduled. Should not be like this that I have searched every book, also the internet. So in desperation, I have come to you, doctor. And this also should not be there. The doctor should not tell the patient that when we want your opinion, we will give it to you. So the final words are, we have to all be an advocate for our patients. Patient safety is everyone's job. When things go wrong, please document, quote the sequence of events. Do not rely on your memory, quote the truth. Only then we will learn. So we have to prognosticate, we have to plan, we have to make policies, and we have to implement those policies. If we don't do this, then we know for the want of a nail, a horse was lost. For the want of the horse, the warrior was lost. For the want of the warrior, the war was lost. In India, hospitals have been burned. People have been beaten up. There have been litigations. There have been resistance. There have been a lot of protests and strikes. So would you like to be this Tomorrow when you go to the hospitals, would you like this to be your regular staff? Would you like this to be your personal limo? Or you want this person to be barking away to be your official spokesperson? I'm sure you don't want anything of this sort. So take these tips. Constitute patient safety committee in your hospitals. Develop policies and protocols based upon your identified patient safety and risks. Orient and reorient hospital staff. Encourage transparency and non-punitive incident reporting by staff. Rather, you should award them for reporting incidents. Each department should devise their own safety protocols. Each investigation of each patient safety incident should be investigated for taking corrective and preventive actions. And regularly, we must monitor, review, and evaluate our safety procedures. So final take-home message is that errors are common in medicine. They make killing tens of thousands. We begin to know something about the epidemiology of error, but we need to know much more. Naming, blaming, and shaming have no remedial value. We need to design healthcare systems that put patient safety first. We know a lot about how to do that. All we need to do is to take initiative. Remember that simple measures will save lives. Remember the measures. Remember that compassion, human touch, and empathy existed. They must continue to exist. Remember that bad systems, not bad people, are responsible for most errors. So do remember you have to change the system and propagate safety culture, a people-based patient safety. Also remember to take the lead and make healthcare safer. My request to you is, please remember to remember whatever you can remember. And this is for you, Dr. Meher. You have always wanted me to say this, so I'm saying this for you. And don't say we have no time. We have every material thing with us to be happy, but for being truly happy, we have no time. We have led a fast-paced life, but for living our own life, we have no time. We are aware of the lullabies that our mothers have sung for us, but to call our mothers, we have no time. We have the numbers of all our friends in our mobiles, but for friendship, we have no time. What do we say about others when for our own self, we have no time? Our eyes are drooping for want of sleep. It is late night in India, but for falling asleep, we have no time. Our heart is full of sadness, but to share our sorrows or shed a silent tear with someone whom we love, we have no time. We keep running in pursuit of wealth, but for rest, we have no time. How we can appreciate others when for our own dreams, we have no time. We have attended a talk on antimicrobial stewardship program and patient safety, but for implementation, we have no time. Thank you very much for your patience, perseverance, and promise to remember. I will not take the quiz because I have no time. Thank you very much. I have finished. I'm sorry, I must have exceeded my time.
Thank you, Dr. Pawan Kapoor. It was a really enlightening, exhaustive, detailed addressing of patient safety, which I'm sure everybody must.
Yeah, I think we are lost to Dr. Reba.
Yes, unfortunately, that looks like that. Till she joins in, thank you, sir, for that immensely inspiring and fantastic, as well as, I can't say hilarious, but something which made me laugh all through, and that is the quality which Dr. Pawan Kapoor you have. You talk about the most difficult topics, and yet you make it so human and you make it so relatable and something which we can actually translate into practice. I hope that our other moderator is here to
Yes.
take up from. Yes, Dr. Zahida, please.
Thank you, Dr. Meher. So thank you so much, Dr. Pawan. That was really interesting and helpful how you managed to get in the large data, but also the personal stories. And I think that's the bit that's so powerful. The question I have really relates a little bit to your very interesting biography, coming from a military background as well. So the question I have is kind of a big question for us to think about, but really interested in your thoughts. When we have industries like airline, the military, oil rigs, etc., and we have a safety failing, that one incident reflects really badly on the whole of that industry. And there seems to be something of a collective responsibility to respond. And we see that now in all of those industries. Yet when there's a safety failing, major ones, in healthcare, we seem to scatter and we don't come with a collective response as an industry. Can you please tell us how we can learn from the military and these other industries and how we can have a collective responsibility and response so that we can maintain trust in healthcare as an industry? Thank you.
Okay, thank you, Rela, for a very wonderful question. I think, see, I come from the Air Force, and you know, in Air Force, the safety of the aircraft is of prime importance. And you know, we keep on saying that, you know, we keep on saying we have almost, our healthcare industry has errors equivalent to 10 Boeing crashes every month. That's what the common statistics tell us. We don't know how far it is true, but I would like to here deviate a little bit from the question that you asked me. I want to tell you, see, in healthcare, in our industry, the patient is the fulcrum. And the patient goes through not one person, he goes through a whole spectrum of persons, right from the receptionist to the super specialist. So the people who are handling him, there are many people. And as you know, when you are, so many people are handling the same equipment or the same patient, the chances of error at every level of interaction will keep on happening. So the problem arises that we have errors at every place, and we have now to pick and plug those holes in every interaction of the patient at every level. That is why I said patient safety is everybody's job. It is not only job of the doctor or the nurse, it is the job of every employee, including the maintenance staff. Now, what happens in the aviation industry? So what happens in the aviation industry? There's a checklist for the ground staff. There's a checklist for the crew. There's a checklist for the air staff who is looking, that is the air hostesses. Everybody has their checklist. More than the checklist, they have to sit down and verify each and every item of the checklist and tick it. They can spend more time in doing it. They can delay the departure of the aircraft, but they will not move forward until unless the checklist has been corrected and correctly ticked. There are no shortcuts. First thing. Second is the crew resource management. In crew resource management, I have seen with my own eyes a lieutenant who is in the first rung is telling a vice marshal who is somewhere equivalent to major general in the army that, sir, you are wrong. He can tell this because he knows that if he doesn't tell him, then the aircraft and everybody in the aircraft is at risk. So this reverence for seniority, this reverence for experience should not be at the cost of reverence for evidence. So in healthcare industry, we should look at evidences. Experiences matter, but experiences should not be at the cost of evidence, at the cost of evidences. Therefore, in healthcare industry, we need to have a collaborative and a cohesive response to patient safety incidents rather than pointing a finger as somebody who has become the second victim of a patient safety incident. The second victim is the person who has committed an error. He becomes an outcast. He is fined. He is everywhere disgraced. He is shamed, and he has to pay out a whole lot of sum of money. Instead of doing that, if you are looking to it, what made him commit that error, go to the what and how and not who has done it. If we all get together and come together as a healthcare industry as a whole, I don't think I should call healthcare an industry, but as a healthcare setup as a whole, and we try to remain together and not castigate a person who has committed some error, but try to find out ways and means of overcoming the error, I think we can definitely learn from other industries and move ahead of them, because we have that commitment to our patient. We don't want to lose a patient.
Thank you, Dr. Pawan, and hopefully these other industries might in time learn from healthcare, we hope. I think Dr. Reba is back.
Yeah.
Should we move to Dr. Reba?
Yeah, hello? Yeah. Can you hear me?
We can hear you.
Hi, can you hear me?
Yes.
Yeah, okay, sorry. I'm so sorry about that. I lost connectivity as usual, you know. Dr. Pawan Kapoor, I had a question to you. My question was that since the patient, as he or she enters the hospital, passes through various instruments, as you put it, would it be, what would your idea be on, starting to train each of these healthcare professionals in terms of patient safety and accountability?
Thank you, Dr. Reba. Yes, I had somewhere covered it in my presentation. I will come back to that point again. You see, we need to introduce patient safety in the curriculum of undergraduates in medical colleges, in nursing colleges, in paramedical schools. We must tell them that they are all, they are all a part of a system where any error on their part can result in more worse repercussions on the patients who visit them, for whom they are being trained. So I am, for one, very, very clear on this. We must introduce patient safety in the undergrad curriculum of all professionals. We must also take into consideration even those sanitary staff, the housekeeping staff. They should not be told you're just here for cleaning. They have to be told that your cleaning makes a difference. You are a mini doctor for the patient, because your cleaning makes a difference in preventing healthcare associated infection. You must tell the same thing to the laundry guy, that whatever linen comes to you, it has to be cleaned properly, because this also contributes to patient safety. You are a mini doctor. So if you tell all your level of staff that you are mini doctors, this training is essential for you, they will get that requisite boost that they are also contributing to the ultimate care and cure of the patient. So I think training is a very, very important activity.
Yes, thank you. Thank you, Dr. Pawan. Any other questions, or I don't see any. Everybody is very impressed with your detailed expose of patient safety, Dr. Pawan Kapoor. And I must thank Dr. Meher for thinking about this topic as part of this initiative of NASH. And it really is very crucial that every individual is aware of patient safety. Thank you very much for your detailed talk, Dr. Kapoor.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you so much, Dr. Pawan Kapoor, and our moderators, Dr. Reba and Dr. Rahila. The entire audience was left enthralled. As usual, Dr. Pawan Kapoor, I think that's no news to you. You have and will continue to enthrall audiences, and I'm sure motivate them towards patient care, better patient care and accountability. And with your excellent take-home messages, I think we're all inspired. Thank you so much.